My name is Dr. Barbara Walsh, and I'm one of the pediatric emergency medicine attendings at the University of Massachusetts Medical Center. I specialize in the education of pediatric resuscitation. I want you to think about this question. Who would you want taking care of your child if your child suddenly stopped breathing, if your child became unresponsive, if your child turned blue? One of the things that I'm working on right now is providing a program out in the community where I bring an infant mannequin that's able to simulate a real-life baby. And I'm running scenarios with our community providers. I have created a new paradigm in medical education. I've piloted a new program using Laerdal's Sim Baby, a high-fidelity mannequin, and I've been going out into the community providing this service. What I do is I bring the baby to each community site. I've now gone over the past several months to local emergency departments, pediatric inpatient floors, and our local fire departments that have paramedics as first responders. I've been running the same scenarios that I've been doing in the pediatric emergency department and working with these groups on team leadership, communication, effective management, medical decision making, and identifying systems issues to help these people provide better care to children. So I wanted to take a minute to show you this amazing piece of equipment that really simulates a live baby to the best of our ability with modern technology. This is the Laerdal Sim Baby. It's supposed to be the size of about a 6-month-old infant. What's fascinating, if you can see in this video, the baby's able to breathe. There are different breath sounds that we can change. The baby can retract. What that means is the baby's chest is moving in a way to let us know that they're struggling to breathe. The baby has a heart rate that we can hear with a stethoscope. We can change those heart sounds. We can simulate a lung collapsing and needing of immediate intervention. The baby turns blue. There's a blue light inside. It's an LED light that shows us that the baby's cyanotic. The baby is in dire straits. The baby has pulses. When I feel the pulses, I can feel for brachial pulses. I can feel for femoral pulses. So it shows that I am actually feeling the pulses. If I want to manipulate the airway to make the baby feel better, I have a screen that shows me that there's a head tilt, that I'm actually making an intervention to help this child. What's great about the baby is we can put in IVs, we can do CPR, we can put in a breathing tube, we can decompress the chest. So this is actually the screen that I am looking at from behind the scenes on my laptop, which is portable. What's great is I have a copy of the vital signs. What they would be seeing is this monitor, but with only the vital signs displayed. I have an image of my vital signs right on the right upper corner, as you can see, and I can manipulate those. When they do an intervention, I can either see it on the baby or I get a time-stamped written report. When they perform an intervention, I am able to click on it down below and I'm able to document that it's been done. Everything is time-stamped, and you can run pre-programmed scenarios so that if you click on certain things, the vital signs automatically change. It's an amazing piece of technology. You can simulate real-life situations. So I can take a case that I've actually had in clinical practice of a child coming in cardiac arrest. I can write a program and simulate the exact case and program it into the computer. It's a pretty powerful tool because you can have as real as a scenario as humanly possible. And when people are in this setting together as a group, looking at this baby who's breathing, the baby can cry, the baby can grunt. They think it's real. They're feeling that stress that you want to feel in a real situation. And it makes them work together as a team and really try and do the best for the mannequin. They really do. It's real.
Laura, if you could draw up to 0.1 milligrams per kilogram of epinephrine, that's going to be 0.8 milligrams, 0.01 milligrams per kilo of epinephrine.
Okay, 0.08.
0.08.
Epinephrine?
Yes.
Do you want to call anesthesia?
Yes.
About a week after I went to one of our community trauma sites, I received a very nice email from one of my former colleagues that was a resident that I trained. She ended up having a critically ill child that came in respiratory failure. She was able to effectively manage this patient, work with her team, institute timely medical interventions, and transfer the patient to our pediatric intensive care unit. She sent me an email telling me that because of this one session of coming out to her trauma bay and running these scenarios, she felt so much more confidence. She said she was able to use the information and apply the skills that she had retained. And she said if she hadn't had this program, she doesn't think she would have been able to provide the high level of care that she did. The child ended up doing incredibly well in our pediatric intensive care unit, was discharged home, and is a happy child running around playing like every other kid. This one success story is exactly what this educational paradigm is about. If I can reach one community doc and help them give better care to a critically ill child, then this program has been a complete success.